Everyone, welcome. It is 2:35 Eastern Time, and we are going to get started. Welcome to the Early Childhood System of Care Learning Community. My name is Lauren Rabinowitz, and I'm here with my colleague and friend Kate Wasserman from the TA Network. She's going to introduce herself in just a moment, and we are so excited to have you all on today to have a great conversation with our colleagues from 0 to 3. We are joined by Therese Ehlers and Jamie Colvard. They are going to give an awesome overview about making appropriate diagnoses and establishing eligibility for infant and early childhood mental health services for that young population that we all work with, and they're going to be specifically talking about the DC-05. So thank you, everyone, so much for joining. Just going to give a little bit of background about our early childhood learning community, and then we are going to get into the content. So this is a time for those of you that have not been with us before. For those of you that have, welcome back. But this is a time when we have folks come together that are either working directly with the early childhood population, or are in the system of care world, or just really interested in learning more about the issues that are specific to young children and their families. This learning community, once upon a time, was just for those that were early childhood system of care grantees, but over time we have expanded, and we are really, really excited to welcome everyone that has an interest in early childhood. So please do tell your friends and come join us. We are holding this time monthly for our time to come together virtually through the webinar platform. And then we also have another way to get in touch and to talk with each other, which Kate is going to talk about in just a moment. So again, thank you so much for joining us. We do have a large group today, so we are going to keep the phone lines muted. If you have any questions, please put them into the chat. That could be a question about something not working with your technology, or if you have any questions for our presenters, please put the questions in, and we're going to keep this pretty informal. We're really hoping to hear from all of you and have some conversation and dialogue, in addition to the wonderful material that our presenters are going to share with us. We also have an evaluation. There will be a link popping up towards the end of the webinar. Please do click on that link and let us know your experience with today's webinar. It's really important that we hear from you all. As I said, we are expanding this learning community, and it is a time for you all. So we want to hear from you. We want to know what is working, what needs some improvement, some ideas you might have for a future topic. We are open and really interested in hearing about all of it. And so along the lines of, I know I just said that we are going to be talking about diagnosis of the early childhood population, and now you're seeing a slide about preschool development grants. It's actually not a mistake. The reason that this slide is up here is because we want to, as we said, this is an opportunity to bring the early childhood workforce together, and we all know that different issues pop up at, different grants come up, and there are all sorts of opportunities that are coming left and right. So we want this to be a learning community where you can connect with folks in real time if something is pressing. So lots and lots of folks are currently working on preschool development grants. We know those were awarded right at the end of 2018, and it is a quick process. Hopefully they'll be expanding and continuing the funding, but right now people are kind of knee-deep in needs assessments and all sorts of different good work. So we're kind of putting this here almost as a little teaser, as the kind of thing that we would really love to have some virtual conversation on through our online learning system that Kate's going to talk about in just a minute. You can feel free to put something in the chat now about it. We are really curious if any of you all are connected with the PDG work in your state or in your tribal nation or your territory where you're from. And if there are ideas or thoughts that you're having on it, this would be a great place to share that. So just kind of putting there as an example of something, we didn't know when these were going to come out, so we can't necessarily plan for a learning community 6 months ahead of time about it, but that is fine because we have a system where we can chat about these sorts of things. So with that, I am going to turn it over to Kate, and she's going to tell you a little more about this before we get into the meat of our talk for today.
Thank you, Lauren. So this is Kate Wasserman with the University of Maryland School of Social Work Institute for Innovation and Implementation, also joining Lauren to co-facilitate these early childhood webinars and learning community for the TA network. And as she said, so we have sort of this standing time. So it's on a Tuesday. It jumps around a little bit because of the schedule, but once a month you'll get an invitation either through your state listservs or through the TA Telegram if you sign up for that on a range of topics that will be through this link, so through this Adobe platform. But we also will have all of the recordings of those on this image that you see here, which is our Learning Management System, or LMS, as the fancy tech folks refer to it. And our goal is really for this to be a place for you guys to go and not only access recordings of webinars that maybe you signed up for, but your day and schedule didn't make it so that you could actually attend the entire thing, or you're sort of looking for some resources around a given topic, but also a place for many of these conversations around the PG development grants or other things to really be a place to have those and get more resources, because often we know that a lot of these webinar topics, people are explaining very briefly what took them and their teams and their states a long time to do, and it's often much more complex than we can fit in a slide or in a 20-minute conversation about it. So really our intention, the link you see at the bottom, this theinstitute.myabsorb.com, will get you into the entire learning management system platform. And then the next couple of slides will take you through what some of the features are of that learning management system. And our goal, as we said, is for you guys to begin to register through that, so that you'll have access to the whole training catalog, all of the recorded webinars as well as upcoming webinars, and then related resources. And then we can message you through that as things come up, or we'll sort of be an entire class list if it takes you back to your college or grad school days. So what you see here is the circle that just came up is the online training. So it says training catalog. That's where you'll access all of the webinars and resources, where you can register for the webinar itself. There's a scrolling thing down here that has social media feeds based on the content that you're enrolled in. So some of it is system of care specific or early childhood specific. And then the learning communities themselves are down here. So these are sort of longer term courses that you enroll in, and then these are the learning community resources, and where you would access this orange tab is where you would access the actual learning communities themselves. You can see when you go to that, which is right here, just zooming in a little bit more on that. Right now there's 3 different learning communities up, and early childhood is one of those there. So you can see the image with featuring some of the early childhood work is right there in the middle. You would just click on that, and then that would bring you to any of the early childhood specific resources. So you would see any pre-recorded or existing webinars up, as well as upcoming webinars, so ones that you could register. And I actually tried this out, and what it does is it creates a calendar invite that you can plop right into your Outlook or Google Calendar, so that it becomes something that your technology reminds you of the day or week before, which is always lovely for me. And then, as Lauren said, there's surveys. We really want this to be something where we're using a CQI process, or we're using information about, what topics got the most interest or sparked the most conversation or had the most registrants, and then building more things from there. We have the capacity to do brief videos and brief recordings. So if there are components of different topics that are either discussed on the webinar, or that somebody did a great deal of work around that topic but they're not able to join for that time, we can always record a brief interview with them and post that up there as well. So when Lauren and I say that we really want to hear from you about those topics that are most interested that you're most interested in, it's certainly authentic. And there's also the ability on there to have public discussions, so resources. And then you can see here that, everything is tagged. So the idea is that, based on your interest, it really builds, different resources around those things, so that all of the things that we put up there are tagged for different search terms. So if you have no idea what you're looking for, but maybe some of the content that you're seeking, you can find some great things. So with that, we're going to pivot back to the topic at hand, which is diagnoses for young kids. And we'll hand it over in just a minute to our colleagues from 0 to 3 to spend the rest of the time really talking to you about the DCO5 and what that means. And because this is a SAMHSA-funded webinar and effort, and a lot of this really comes out of the system of care work, I want to give a brief caveat before we hand it over. And just explain how within the system of care world, so this next minute and a half is actually really only relevant to system of care grantees. But because those funds, the legislation that releases those funds to SAMHSA to release that to us, to different entities and tribal communities and states, is really tied to very specific language around mental health need and imminent risk. We have done a lot of work with them, and others before us have done a lot of work in the past several years about what that means for early childhood, because so much of that work is really happening on a continuum where there are, mental health consultation and prevention services that, or things like ABC that are clinical but not necessarily offered by a clinician. And so all the slides and the discussion today will focus on appropriate diagnoses that we really endorse any team to use, but to know that also there's this sort of imminent risk category for system of care to sort of qualify folks for those services, and that would come into play really only if you don't have a license to diagnose. But are there ways that you can document that there's an imminent risk for a mental health diagnosis? So for young kids, imminent risk doesn't mean of harm of self or others the way that it does for older kids, but it's really much more about that they are in imminent risk of developing a mental health diagnosis, and so that therefore it would be appropriate to intervene. But wanted to sort of think about that and be able to speak to that since this is something that started through the system of care world. And with that, we're going to pivot over to our colleagues at 0 to 3. I'm going to take just a minute to introduce Jamie, and then Lauren will do the same for Therese. So Jamie Clovard is a Senior Technical Assistant Specialist with 0 to 3 Policy Center. Her work focuses on issues including home visiting, infant and early childhood mental health, state advocacy, cross-agency collaboration, and other aspects of creating comprehensive early childhood systems to support infants, toddlers, and their families. She supports states through technical assistance, research, and analysis, and the development of written products and tools. And we're going to send you a bunch of those through the Absorb link and also through an email after this. Don't worry. We're just letting you know all this now to pique your interest. In addition to supporting states involved in financing policy projects around IECMH, her current projects include supporting state advocacy organizations to implement the Think Babies campaigns, to advance policies supporting infants and toddlers at the state and local levels as well, and to co-facilitate cross-state community of practice, focusing on home visiting resources. She formerly served as a resource specialist for Project Launch Resource Center within 0 to 3. And prior to joining 0 to 3, Jamie worked on the program and policy staff at Grantmakers for Children, Youth, and Families, and held several managerial and marketing positions within a regional law firm in California. She earned her MPP from the Court School of Public Policy at Georgetown University and her BA from Linfield College. And Lauren, I hand it back to you.
All right, thank you, Kate. So I am lucky enough to introduce Therese Ehlers. She is a Senior Technical Assistant Specialist working on infant and early childhood mental health policy at 0 to 3. Ms. Ehlers started with 0 to 3 as a resource specialist for Project Launch. In this role, Ms. Ehlers provided technical assistance on state and community early childhood wellness promotion strategies, including early childhood mental health consultation to launch grantees. Prior to joining 0 to 3, Ms. Ehlers served as the founding executive director for Wisconsin Alliance for Infant Mental Health. In this role, she convened 2 national infant mental health summits in 2005 and 2007. Prior to this, while working for Wisconsin Medicaid, Ms. Ehlers was involved in the early system of care grants and wrote the first contract establishing Wraparound Milwaukee, which we all know is something we still turn to all the time for lots of important lessons learned. 5 parents were involved in the development of the Wraparound Milwaukee Managed Care Contract. Ms. Ehlers has 10 years of experience working with adults with disabilities and over 20 years experience working on mental health policy. Ms. Ehlers is endorsed at Category 4 as an infant mental health policy mentor and is a 2003 0 to 3 graduate fellow. She received a Master of Arts in Public Administration from the University of Wisconsin-La Follette Institute of Public Affairs and a Master of Science in Behavioral Disabilities and Rehabilitation Psychology. So we now turn it over to our colleagues at 0 to 3, Jamie and Therese. Thanks so much.
Thanks, Lauren. So hi, everyone. This is Therese, just so you know my voice. I'm really, really excited to be doing this. It kind of feels a little bit like Old Home Week because my understanding is many of you are involved in the system of care grants, and as Lauren just said, I was involved in one of the early system of care grants, Wraparound Milwaukee. And then my understanding also is that there might be some launch grantees. So hello to everyone out there. So I'm going to start, as Lauren and Kate just read our bios. Both Jamie and I work for an organization called 0 to 3. My guess is that many of you are familiar with 0 to 3, but I just wanted to say a little bit about it. 0 to 3 started in 1977, so over 40 years ago now, which is a little hard to believe. But anyway, what I really like about 0 to 3 is it started with a bunch of people, luminaries now that we consider luminaries in the field of infant mental health that came together from time to time to talk about, what are babies all about? What's going on in their heads? And all of them had a firm belief that relationships matter. And they were all committed to something called infant and early childhood mental health. It might not have been called infant mental health, but at one point in time there was this debate about babies being a blank slate, and these folks, did not believe that. And over 40 years later, we have an organization now called 0 to 3, which is a full-service approach to infant mental health. I love that 0 to 3's roots are in infant and early childhood mental health. So what do? We do things like policy and advocacy. In Jamie's bio, they talked about Think Babies. That's a big advocacy activity that 0 to 3 is involved in. We also provide technical assistance and consultation. Both Jamie and I, on a regular basis, provide technical assistance. We also, 0 to 3 also provides professional development on a whole host of topics regarding early childhood. There's also a leadership development program. This is through the fellowship program, which I participated in, and Kate Wasserman is also a graduate fellow. And then finally, there's parenting resources. But at the heart of it, what 0 to 3 does is help babies and toddlers benefit from the family and community that they're surrounded by. People have heard the term, it takes a village, and it truly does. The mission of 0 to 3 is to make sure that all babies have a strong start in life, and that there's a society that has the knowledge and the will to support all infants and toddlers in reaching their full potential. So today, what we're going to talk about, a big focus of today's talk, is the DC-05. The long name, we always seem to have long names for things, is the Diagnostic Classification of Mental Health and Developmental Disorders of Infancy and Early Childhood. Originally, this was intended to complement more familiar systems. And my guess is that most of you know what the DSM is, the Diagnostic and Statistical Manual of Mental Health Disorders. What 0 to 3 felt is that the DSM didn't really fit for infants and young children. There was a need for a classification system that was much more specific to early childhood. So in 2016, what was released was the DC-05. But the DC-05 has a history, and I'll get to that in just a moment. What I'd like to talk about is the infant and early childhood mental health continuum. Sometimes, people have a concept that infant mental health means mental illness, and I don't want people to conjure up, the baby on the couch or diagnosing 18-month-olds. Infant mental health really is a continuum, and if you think about it, we all have mental health. Mental health is not a bad thing, but the continuum starts with promotion. And promotion would be raising awareness to encourage healthy social emotional development. Getting parents and other caregivers to sing to their baby, talk to their baby, name things with their baby. Next in the continuum is prevention. This would be prevention activities would be identifying risk factors that or mitigating the impacts of ACEs, adverse childhood experiences, and intervening in the child and caregiver relationships that threaten healthy development. And then often people jump to treatment, providing evidence-informed services and supports to address mental health disorders. But the very, very important piece between prevention and treatment is that developmentally appropriate assessment and diagnosis. And that's where the DC-05 comes in. So what I'd like to do is give you the definition of infant and early childhood mental health. My guess is that, most all of you know that, but I talk a lot, and I have talked a lot over the last several years about infant and early childhood mental health, and I always make it a point of giving the official, quote unquote, definition of infant mental health, in part because it's often misunderstood. Like I said, oftentimes people want to go immediately to mental illness, or some people think that infant mental health is just prevention, and they forget that there's this whole, or they don't know that there's this whole continuum. So infant and early childhood mental health. It's synonymous with the term social and emotional development, and it's the developing capacity of the child from birth to 5 to do a number of things. 1 is form close and secure adult and peer relationships. 2 is to experience, manage, and express a full range of emotions. And then finally, explore the environment and learn. And this is all in the context of family, community, and culture. Other ways of describing infant and early childhood mental health. I'm sorry for that noise. It's my bird clock telling me that it's 2 o'clock. It'll end in a moment. So anyway, other words to describe infant and early childhood mental health or social emotional development. It's the capacity of a child to develop persistence, to develop perseverance. It involves motivation. It involves trust. And all of these things are essential elements to successfully learn. I like to think or say that infant and early childhood mental health is the foundation of all future development. The future development such as physical development and cognitive development, memory, language. It all has its roots in infant and early childhood mental health. So why are we talking about a diagnosis? We're talking about a diagnosis because there's a value in a classification system. We need to have, if you think about the people that are involved in a child's life, those people, and a child that has no specific challenges, that could be the parents, extended family, child care, maybe home visiting. So those folks are all interacting with that child, and we need to think about what they know about infant and early childhood mental health. But if that child has challenges, the list of services and the list of providers increases. um, and could include specialized medical professionals, early intervention folks, child care, home visiting, as I mentioned before, and people in specialized medical fields. So these providers from the different service delivery areas have their own language. And what the DCO5 provides is that it ensures that everyone has a common classification system, that if a child has a diagnosis of separation anxiety disorder, people know what they're talking about, that the providers involved have a good idea of the child's condition and symptoms. Secondly, an accurate diagnosis can also lead to appropriate treatment. It only makes sense that in order to know what to do or how to intervene, it's imperative that you know what's wrong. And knowing what's wrong is, a compilation of symptoms and circumstances. So, of course, the clinician's observation skills comes into play, but you also need an accurate diagnosis for that intervention. If clinicians use the DSM, which is the more common diagnostic tool for older kids and for adults, they're picking and guessing on a code that most resembles the child's challenges. The DCO5 is specific to infants and young children. Something that we have to remember is that infants and young children grow in the context of relationships. And the reason why the DSM does not work for infants and young children is it's not subtle enough to pick up these relationship disorders. Because infants and young children grow in the context of relationships, oftentimes that's where their mental health challenges arise, within the context of relationships. So the DSM is more appropriate for older kids, where the DCO5 is more appropriate for infants and young children. Also, the accurate diagnosis potentially could lead to additional services. I'm sure many of you are familiar with EPSDT. With EPSDT, additional services that are medically necessary to correct or ameliorate conditions discovered in children through screening are covered under the EPSDT benefit. And that's regardless of whether or not those services are included in a state's Medicaid plan. So the accurate diagnosis is important in leading to appropriate treatment and needed for additional services. The third reason is diagnosis supports medical necessity. Payment requires demonstrating treatment is necessary, and in Medicaid, a very important term is medical necessity. Medical necessity is often defined based upon a diagnosis, so this diagnosis validates treatment. And then finally, we also need reimbursement for the services provided. And this is, very, very closely tied to that medical necessity. Third-party payers, regardless of the payer, require an ICD-9 code, which corresponds to the diagnosis. And the DCO5 provides that diagnosis, which is crosswalked with the ICD-9 code. So, really it's a balancing act. And we're not suggesting that, that we willy-nilly diagnose kids because, every child is unique and every child, develops in their own unique way. But we do know that infants and young children can have mental health challenges. And the earlier we diagnose if there really is a challenge, the better the outcomes are and the earlier that we can intervene. And what this slide really illustrates is that it's the constant balancing act that providers need to attend to when diagnosing infants and young children. The DCO5 was put together by a task force from around the United States and some international people. And the manual was created to take away some of the precarious nature of this balancing act, trying to figure out, well, is this normal development or is there really something wrong? So the DCO5 supports clinicians in making this decision. The DCO5 has 5 axes. It's similar, the axis is setup is probably familiar to many people that are familiar with the DSM, but the appropriate diagnosis of an infant or young child would take multiple modes of assessment. Some of the things involved would be interview with the primary caregivers, especially with, a baby. A baby doesn't talk with words. They do communicate, as we know, but not necessarily with words. If a child is a little older, you would want to have interactions or an interview with the young child. The clinician would collect collateral information, maybe information from the home visitor or information from the child care provider. There would also be involved formal or unstructured observations. Unstructured observations with the child as well as with the caregiver, between the caregiver and child interactions. Trying to see what is the dance happening between that child and that parent, or that child and that caregiver. Oftentimes there's formal testing procedures done, diagnostic tools, and then what also does come into it is observation of the clinicians, reactions and associations. Oftentimes what we suggest is that a full evaluation or an assessment would be done over a series of several sessions. 3 to 5 would be recommended by the task force. Oftentimes in the third-party biller world, including Medicaid, there is only one assessment session allowed. And what we would suggest is that they offer and reimburse for more than one, such as 3. And a couple of states, including Minnesota, have done that. So the DCO5, as I said earlier, the ICD-10 is the coding structure that is needed in order to bill. There is a crosswalk that was created, and this crosswalk goes from the DCO5 to ICD-10 codes. And the crosswalk is available at the link provided here. But I would caution you or suggest that, if your state is interested in using a crosswalk and something in the crosswalk that the example that 0 to 3 has provided doesn't quite work for you, it can be tweaked. It can be tweaked and used, to meet the needs within your states. Oftentimes people say if you've seen one Medicaid program, you've seen one Medicaid program, because the states have the ability to implement Medicaid, within their state with the guidance of the federal government. So there's quite a bit of variety from state to state to state. So places have taken the DC-05 crosswalk to the ICD-10 codes and used the 0 to 3 crosswalk as an example, and then tweaked it from there to make it work within their own system.
Therese, this is Kate. If I could just chime in there, because we are in the process of doing that for Maryland, and it's a really helpful tool. So in your state plans, you can actually see what codes are open or closed for your state, and then you can sort of see, so using the 0 to 3 crosswalk as the base, which ones are we able to actually bill for in our state, and then it just makes your crosswalk longer or shorter, essentially. But more informative to the workforce specifically. Yeah. Thank you.
Right. So some states don't allow certain codes for whatever reasons, and I'm sure there's valid reasons. So if that's what we've crosswalked, it's helpful to know that and to adjust accordingly. So now I'm going to turn it over to Jamie, and what Jamie's going to talk about is how states are integrating the DCO5 into policies and practices. And from my perspective, one of the challenges, particularly in the mental health world, is that the mental health system was initially developed for adults. And it was really, based upon an adult system. And then, through a series of things, of events, one being the book Unclaimed Children by Jane Nitzner, children's mental health issues became more apparent, particularly kids with serious emotional disturbances. And now we have this thing called infant and early childhood mental health. It's kind of the last hurrah for mental health with regards to ages. So we really need to work on, how states are integrating the DCO-5 into policies and practices, because it's not a given. The mental health system isn't always responsive to infants and young children's mental health needs, and sometimes they're not even aware of them. But then we also have the payers, specifically Medicaid and other third-party payers. So I'm going to hand it off to Jamie, and she's going to tell you a little bit about how states are integrating the DCO-5. So Jamie, take it away.
Great. Thanks, Therese. So as Therese mentioned, I'm going to talk a bit more about sort of the policy side. And this question came up. One of the projects Therese and I both work on is an infant and early childhood mental health financing policy project, where we've been working with now 2 cohorts of states who have brought teams together to try to advance infant mental health policy at their state level. And the first cohort happened to coincide with when the DCO-5 was released, and a question we got from people was, okay, great, this sounds wonderful, we want to use it, so how should we do that? And so after a bit of time after DCO-5 was out, we conducted interviews with people across the country and states to hear really what they were doing, what was working, what wasn't working, so we could sort of share that information with other states. And out of those interviews, we developed a paper, which will be shared on your platform after this webinar, kind of summarizing what we heard from states. And you'll see here on this slide, there were sort of 4 themes in how we were hearing states were advancing the DCO-5 and putting it into policy, practice, and systems. So the first is to formally recognize DCO-5 in your insurance programs, including Medicaid. The second was to develop and disseminate resources such as crosswalks or other guidance to really support providers to use it both, in their work with children and families, but also on the, trying to get billable reimbursement for those services. Third is to think about how DCO-5 diagnoses might be used as eligibility criteria for other systems, such as Part C early intervention. And then fourth, including DCO-5 in cross-sector infant mental health workforce development efforts. So I'm going to go into these in greater detail and share examples from what we saw states doing. And then at the end, I'll also share some of the other kind of promising avenues that we've seen states start to take steps into beyond these. So first, one way to ensure the use of DCO-5 is to include a requirement in your Medicaid language or contract language. And one recent example of a state that has done that is Arkansas. So in 2016, the Arkansas legislature approved a big behavioral health transformation package. And within that, it included changes to Medicaid that were really aimed at improving diagnosis and treatment of very young children who had mental health disorders. And this went into effect in 2017. And what the language said was that it called on providers to use the DCO-5. I think the words used were the previous version, the DCO-3R. Sometimes that's occurred, and it includes, and all future revisions. So it called on providers to use the DCO-5 to diagnose children aged 0 to 4. And in that language, it recognized that use of an age-appropriate classification system would improve the chances that children would be appropriately diagnosed and then referred to evidence-informed treatment. And it also, in the language, specifically told providers to crosswalk the DCO-5 diagnosis then to the Division of Medical Services Diagnosis for reimbursement. So it was specifically drawing the link between using it for diagnosis and for reimbursement. And the rule package also changed policy so that for the first time, Medicaid would reimburse providers for dyadic therapies, which treat young children and their caregivers in the context of their relationship, which really ties into how you're using the DC-05 for assessment. Now, going through a change like that is not easy. It's not quick. In Arkansas, it was really the result of about a decade of work by the Department of Human Services, clinicians, and families who really advocated for change. And just to give you a sense of what went into that, some of the really pivotal moments were in 2006, the state dug into their Medicaid data, and they found that there was a high usage of psychotropic medication being used for children. They realized that they didn't really have billable codes or services in the areas of substance abuse and infant mental health therapy. And they didn't have a lot of certified clinicians who could work with very young children. And so they saw these gaps and they started working to address them. Another really key pivotal moment for them was that the First Lady at the time led a listening tour throughout the state to talk with parents. And that really affected her, and it really drove some of the work at the state. They created a Children's Behavioral Health Commission to support the First Lady's work and really dug into this. And at the same time, then the adult system was going through some transformation as well, and they ended up merging it all to work together, which then led to this really big change package. So I would say a lesson from that state's experience is to think about who your champions are. The First Lady, in their case, was a really big champion to kind of move these things forward, as were the stories of families. And so thinking about that if you're moving things forward. You'll also see on the slide that Nevada, their Medicaid manual included mention of DC 0 to 3R, which was the previous version of DC-05. And it also allowed diagnoses to be recorded in electronic health records. Although in a recent revision, I think 1 or 2 years ago, DC-05 is no longer mentioned by name. Medicaid still encourages clinicians to use it. And Nevada is one of the states participating in our financing project, so they're working really close with Medicaid right now to promote DC-05, and they're bringing training for it back to the state now so that people understand how to use the revised version. One other example that's not here on the slide, but I thought I'd mention, is in Virginia, when their state went through managed care, they were putting out their contract again. Stakeholders put into public comments that they wanted infant mental health language included in the RFP for managed care. And so they were able to kind of bring infant and early childhood mental health to the table there, and it was mention of it was included in a model contract for their MCOs. And so that was a great way to sort of move that forward and make sure whoever is providing services through Medicaid kind of understood what that was. So often, policy change doesn't have to go through legislation. There's lots of opportunities to do things at the agency level. One example is from my home state here in Oregon. Although Oregon had a crosswalk to the DC 0 to 3R, which was the previous version of DC-05, they realized that there was still a lot of confusion among clinicians about what Medicaid would actually reimburse for, what services were out there. And so when the DC-05 was released, and they had a team thinking about, okay, what do we really need in our state? They realized that really the first step was to just help people understand what they could already do. There's always room for improvement in your Medicaid policy, but if people aren't taking advantage of what's already there, that's, a big problem. And so they had a team that came together and updated their crosswalk to reflect the DC 0 to 5. And then they thought about what the barriers to the previous version being used were. And a couple of things that they came up with were, one,
Oregon has some state-specific components of their system, one of them being a prioritized list where a line is drawn and anything above it is reimbursable and anything below it is not. And so they added information about that prioritized list to their crosswalk. They also added information about how it should be used and how to really demonstrate when you're submitting for reimbursement how the DC-05 was used for diagnosis and how it was then crosswalked to the billing code. And then once they had that crosswalk finalized, they posted it on the Medicaid agency's website. And that was a way of sort of affirming that this was a Medicaid-supported effort and that Medicaid sort of approved that crosswalk for use. And then this team really took that on the road. They went and presented about DC-05 and the crosswalk to anyone and everyone who would listen, from clinicians to managed care groups to early childhood collaboratives, everywhere really. And they also had a couple, they contracted with 0 to 3 to do a couple sort of official DC-05 webinars. And they found that sort of this outreach and the state-specific information really helped it be used more. Therese mentioned Minnesota earlier. As part of a larger state initiative to expand infant and early childhood mental health services, Minnesota changed their Medicaid outpatient rules in 2011 to require that providers use the DC-05 or the DC 0 to 3R and subsequent revisions, again with a state-provided crosswalk, and they did that mandate for children less than 5. And they are also one of the states that enacted an extended diagnosis rule, recognizing that children and adults who have complicated cases, you may need more than one assessment meeting to diagnose. And so they will cover up to 3 sessions at a higher reimbursement rate to make sure that that assessment and diagnosis is done appropriately. And similar to Arkansas, Minnesota also covers dyadic therapy if it's required. So the third strategy that we really saw states taking up is using DC-05 diagnoses as eligibility criteria for Part C early intervention. Again, here we have an example from Minnesota. Minnesota's Part C program was under review because they had low enrollment. And in thinking about how to make sure that they were connecting with the children who could benefit from services, one thing they realized is they could make it so that children with specific DC-05 diagnoses would automatically qualify for Part C services. And they just went through, I believe, over the summer reviewing the list of the diagnoses that would be approved for that. So I think when that's final, that could be shared if anyone's interested. But really, these were conditions that they said would constitute a high probability of delay. New York also has...
Can I ask a question really quick? I think Part C is a really innovative place to think about the DC-05. And did they have like clinicians that were embedded or consultants that were sort of there that had a mental health license that were doing the diagnosis, or did they get all of their service coordinators trained in it? How did they actually, like, what was the workforce mechanism to deliver these DC-05 diagnoses to kids?
Good question, and I'll share what I know and then see if Therese knows more, but I don't believe it was Part C staff using the DC-05. I think it was making sure that mental health was connected to Part C.
Okay, that makes a lot of sense.
Yeah, that's correct. That's correct, Jamie. And what I find intriguing about Minnesota is they expended a considerable amount of mental health block grant in training mental health clinicians. And there's a nice connection between Part C, when the Part C folks have some infant mental health training. Obviously, they're not clinicians, but they know enough of when to refer to an infant mental health clinician. And Minnesota did this massive training of infant mental health clinicians on on the DCO3R and now the DCO5, and then have learning groups as well associated with them. So referrals are done in an easy manner with an assessment.
Makes sense. Thank you.
Thanks, Therese. So New York also has identified 2 specific DCO5 diagnoses, which you see on the screen, that can provide that provide eligibility for Part C, and then they also note that other disorders can provide evidence toward eligibility. And their Part C program developed a paper with case examples using DCO5 and guidance on supporting young children with early intervention, I think last year or the year before. It's called Meeting the Social Emotional Development Needs of Infants and Toddlers, Guidance for Early Intervention Program Providers and Other Early Childhood Professionals. And I can't remember if we already shared that, but we can. If we didn't already, it might be an interesting thing to look at. I know a couple of the teams that I'm working with in the state through our financing policy project right now have brought in people from Part C to join their teams to really think about how they're strengthening the connection between Part C and infant mental health. And it's definitely part of the workforce that they're trying to connect to. And sort of that's a nice segue to the last area that we really saw states doing some work to embed DCO5 in their systems is through professional development. So, you know, the official clinician-oriented DCO5 training can be really important for clinicians to know how to use DCO5 to inform their diagnosis and consider aspects of the caregiver-child relationship that affect development. But training on DCO5 in a less, not clinician-oriented way can also be helpful to other early childhood professionals such as home visitors, early care and education providers, Part C, like we said, et cetera, as a way of increasing their understanding of infant and early childhood mental health and the array of supports that are offered in states to support, children and families who are experiencing issues. And training can be paired with information about services that you can refer to, what to do if you suspect a child has a mental health problem. I think one thing we've seen is that sometimes the broader early childhood, system, the professionals working in it they aren't even really aware of what services are out there. And so sometimes the thought is, why, if there's nowhere to send someone, why should we be looking for this? So really helping people to see how infant mental health, fits into the system across the continuum that Therese mentioned earlier, from promotion, prevention, diagnosis, and treatment, and seeing sort of their role and that there are supports out there for children. So there's a handful of examples here on the slide, and more in the paper that I mentioned, but I'll just mention a couple. So in Colorado, they used some of their project launch funds to expand DCO5 training to their infant and early childhood mental health consultants to understand infant mental health disorders and how to communicate the clinical needs. They've also trained clinicians, child psychiatry residents, and clinical supervisors. Michigan is now using mental health block grant funds to do training on the DCO5. They previously trained clinicians on the DC0-3R, and they're also embedding some of the information about the crosswalk into their training to make sure providers know how to bill. In New Mexico, the New Mexico Department of Children, Youth, and Families has used state general funds to provide training to agencies and clinicians, primarily in 2 areas of the state, with a particular focus on teams working with children in foster care, so trying to bring that into the child welfare system. And they also have supported case consultation networks with clinicians. So, receiving the training is really good, but once clinicians start using the DCO5, it can be really helpful to talk through, cases so you can understand how clinicians are really using it to come to a diagnosis and treatment plan and talk about that together. It sort of helps your own learning and think about how you can implement it.
And then New York is one of the states that piloted 0 to 3's train the trainer training for DC-05. So when the DC-05 was first released, 0 to 3 had trained a certain number of expert faculty that were then qualified to offer the training to others. And now 0 to 3 has also, piloted this train the trainer so that people in states can become certified trainers. We know that's a more sustainable way if you have people in your state who are able to provide the training, so you can do it on an ongoing fashion. So just to summarize again, these were the 4 strategies we just talked through. I think we also identified sort of future directions and other areas of need that we see states paying attention to. One of them, which I'm sure you are aware with, is just acknowledging that qualified infant and early childhood mental health providers are scarce. So making efforts to increase the workforce overall is really important. And then, ensuring that the reimbursement for infant mental health services is adequate. One step is definitely making sure that it's recognized and in your system, but making sure that what the reimbursement amount is actually sufficient for what clinicians are doing is really important. I talked about how Virginia included infant mental health language in their managed care contracts, thinking about your system, and if it is managed care, thinking about how you can influence managed care organizations is a really good opening point. And thinking about including DC-05 training in requirements that you may have in your state for different provider types as you're thinking about revising those qualifications. I'll close. I know this was a lot of information thrown at you, just with the reminder that we have a paper that sort of goes into this DC-05 topic and has additional information on the examples I shared and additional examples as well. We also recently released a paper that is related called Exploring State Strategies for Financing Infant and Early Childhood Mental Health Assessment, Diagnosis, and Treatment. And that paper summarizes a cross-state convening we held back in May with those members of the Financing Policy Project, summarizes the themes that came up in those conversations and kind of discusses strategies that those states were pursuing. So I encourage you to look at both of those if you're interested. And now, after all that information, I'll just open it up if people have questions or comments, or if you're doing things in your state that you'd like to share. We'd love to learn from all of you about what you're doing, what your issues are, how 0 to 3 can help, any comments. We'd love to hear them.
And just a reminder, we do have the lines muted right now, so if you can please put any questions in the chat, like Jamie said, we would love to hear from you. Maybe folks are thinking of some questions. Thank you very, very much, Jamie and Therese, for a wonderful overview on a really complex topic, and particularly for having such thoughtful considerations of how hard this work is. And it's so helpful to hear the different examples of how states have done this, and really appreciate you showing the many different ways that this can look at sort of that policy level. It was really helpful. One thing I was just sort of curious about or thinking, and your paper might go into more detail on this, but I think we have folks on this particular learning community from lots of different backgrounds, and are in different places in their systems of care. And I think I know for me sometimes what feels really daunting is just where to start. So you gave some really nice, really good kind of guiding principles and strategies. I'm curious if you have any thoughts on places where somebody could start if maybe you don't feel like you're in a particular, like a decision-making or a really strong leadership position. Like, do you have any thoughts on that, either you or Therese, kind of where one can get started?
I can jump in here. This is Therese. One of my feelings is that, we talk about how infants and young children grow in the context of relationships, but I think our work is also in the context of relationships. So my suggestion is my experience is that often people find Medicaid daunting. It's confusing, it's cumbersome, it's intimidating. One place to start is to set up a meeting with one of your Medicaid people at the state. I guess the first step would be figuring out who that was, but not to go in with an ask, but to say, how do we in our state, pay for medically necessary infant and early childhood mental health treatment? I mean, that's a really good start of learning how it's being covered now. And maybe it's not covered, but the added benefit of having that conversation is then you get to educate that Medicaid person that there is such a thing called infant and early childhood mental health. Oftentimes, the agencies that know most about infant mental health are child welfare and home visiting and child care, because they see the kids in there, but it's not always mental health and Medicaid that understand infant and early childhood mental health. So my recommendation, and I would encourage people to learn as much as they can about how their state addresses infant and early childhood mental health. And maybe a good place to start is Medicaid, but perhaps in the other areas as well. Do you have mental health consultation in child care? Is there reflective supervision or reflective consultation in home visiting? Where does mental health show up across the various service delivery systems, and then how is it paid for through Medicaid?
I love that. Thanks.
Great. I'll just add, this is Jamie, that I also think sometimes people don't realize that what they're doing would be considered infant mental health. So, thinking about that continuum of promotion, prevention, and treatment, helping people to see where they fit into that. So if you have groups in your community or in your state that are focused on early childhood, whether that's an early childhood advisory council at the state level, or maybe there's a community birth to 5 group, or a, group focused on health, going there and asking these questions too, or even kind of bringing it to places where you already sit, like raising it as a topic, I think is a good place to start, because people may not be using the words infant mental health, but what they're doing is sort of fitting that need and just thinking about that.
Jamie, this is Kate. I was going to say the exact same thing at the exact same time. I think, one of the things that we've been doing in Maryland is really, taking a survey of the, both conversationally and actually, through call tracks of the engaged providers to see, like, what services they offer, what reimbursement sort of rates they're seeing, what diagnostic codes they're using, what trainings have they gotten, kind of, really getting a sense of who's at the table and who's at what table, and what might be needed to sort of have a unified voice among those that are working in the field. And then it makes that Medicaid ask or that Medicaid discussion not quite as scary when you're able to not just go in on what you're seeing in terms of the need for kids and families, but also, with respect to where the workforce is, and if there is a unified ask or summary of asks, it makes it a little bit stronger.
Yes, definitely. A couple of the states that I'm working with have also been doing surveys, and they did find, like, they realized when they piloted it, they didn't want to have, like, the name of the survey be something like infant mental health clinician or something, because there were so many people who didn't identify themselves that way. But when you dig into their answers on what they were providing or their training or who they were working with,
the people administering the survey would have classified them that way, even though they wouldn't. So that's good. And I'd circle back to something you guys shared at the very beginning of the webinar, the preschool development grants, first to 5, those don't have, they're not focused explicitly on infant mental health, but they're focused on the full, first to 5 mixed delivery, early childhood care and education system, right? So, and they're meant to connect that system with all the other systems touching families. So I would strongly encourage those of you on the call, if you're not involved with those groups yet, get yourself invited to a meeting, go sit there and bring your expertise to make sure that, this is being brought in, the infant mental health work that you're doing is brought into those discussions, because, it can be hard for us in early childhood. Everything is often very siloed, but you don't want it to feel that way for the family.
Jamie, this is Kate again. I think, we've been really struggling with that a little bit as well. I wonder what you guys have seen from the sort of view from the balcony, working with so many different states, just in terms of comfort around language. We have a statewide infant mental health consultation team, and they're often calling themselves things that don't sound like any of those words. and I think it happens in a range of places, like you're saying. And so I'm wondering if you've seen places make that shift and what that's been like. And I always wonder in my mind as we're having those conversations if we as the mental health field are more careful about the language than we need to be, and if there's some benefit in just owning the term that we all went to school for, or what people's thoughts are there.
Yeah, I want to hear Teresa's thoughts too, but I feel like I've heard different things from different states. It really depends on your context. I do think there's value in sort of owning your language and using it and sharing that, the definition that you've agreed on, and helping people see. But I also think that depending on who you're talking to, different words might work. But when we talk with policymakers, we may use, social and emotional health or well-being instead of infant mental health. A small tweak might be helpful. And we did do, we mentioned this before, but we did do a couple of years ago some messaging research that we could share that's up on our website related to infant mental health. But I do think it really, I think it depends on your audience, and then it depends on sort of the level of, I guess, awareness that people in your state have. But I think regardless of what you use, having the conversation so that those of you who are kind of making the case for it are using the same language, I think that's, and agreed on what the definition is, I think that's important. But Therese, do you have thoughts or what you're seeing from your states that you're working with right now?
Yeah, I would agree with what you said, Jamie, that it really depends upon the context and where you are. I know this was several years ago that in the state of Washington, they were very close to passing an infant mental health legislation, and it got defeated because people interpreted infant mental health as people trying to drug your baby, basically.
Oh, wow.
But at the same time, this is me talking. I just feel like, we need to educate, we need to do a better job of educating people about what mental health is in general, that we all have mental health and that it's not a bad thing. And so, I think 30 years ago, people didn't know what an email was or what internet was, and look at it now. And I'm not suggesting that that's where we're going to be in 30 years from now with infant mental health, but it's a real conundrum, and I don't know if there's a simple answer to that. You all know your states and your communities and what's palatable within those environments. Some people have chosen not to avoid the words infant mental health and say social emotional development. But that's one of the reasons why I always, regardless of the audience, give the definition of infant mental health and make a point of saying that it's not a bad thing. So it's not a simple answer. And I think it's something that people struggle with on a regular basis.
Yeah, indeed.
Yeah, well, and this is Lauren, and I mean, it's so interesting to hear, you know, so we're having this conversation sort of in the context of young children in diagnosis, and Jamie and Teresa, you both touched on this, and you know, I was, as you were talking, I was making sort of a mini word cloud of the words that were coming up, and, you know, whether you're talking about the diagnosis or the policy piece, you know, I was hearing the same terms. You're talking about workforce, and you're talking about quality care, and I heard the word family a lot, and, you know, communication. So I think, I mean, Kate, that is such an interesting question. I think you're very right that we spend a lot of time sort of tiptoeing around these words because we are fearful of you know, upsetting the apple cart. But it's a really excellent point all around that, to the extent that we kind of call out what it is that we're trying to do and make sure that everyone has the right definitions, that, you know, infant mental health is not a baby on the couch. I think we're making some progress there, but we definitely have a long ways to go. But thank you for sharing all that. It's making me think a lot about some of the work that I do also in the home visiting world, where we have really very similar conversations. So it doesn't always matter which arm of the early childhood world we're in. These conversations have a similar feel.
Yes.
Other thoughts or questions from our participants? Jamie said it was definitely a lot of information, really, really great information. We will definitely be following up to send you out the links to some more resources so you can have some time to digest all this.
And we'll also send you the recording, or send a link to the recording. It'll be available through the learning management platform, so that if there are folks in your agencies or down your hall or in your own Medicaid systems that you think would benefit from hearing some of this, you'll have the link to share with them.
But if everyone would like to enjoy 13 minutes back in their day, we can also certainly end early, allow some transition time. Looks like we might have one question coming into the chat. We'll just hold. Oh, all right. You are very, very welcome.
Which we agree. Thank you so much for your time and expertise today. We really appreciate it.
Okay, thank you, everyone.
Yeah, thank you. We will be following up, and we will see you all next month. Thank you so much. Take care.